Hello, everyone, and welcome to this IPCRG and COPD Foundation combined program on looking for patients with early COPD, making a diagnosis and assessing, because overall, what we'd like to do is reduce the risk in these patients with COPD. My name is Alan Kaplan. I'm a family doctor from the north part of Toronto in Canada. I'm the chairperson of the Canadian group in the IPCRG, the Family Physician Airways Group of Canada. And I was actually there in 1999 when this whole thought of IPCRG was actually created. You can see I work with just about every company that makes everything inhaled. So I'd like to say that I'm so conflicted, I'm no longer conflicted. And before I introduce my co-presenter, I just want to particularly thank Dr. Miguel Roman Rodriguez, who is a co-author on the early diagnosis of COPD template that we've actually created for the IPCRG in the past and are updating currently. Anna?
Yeah, hi everyone. My name is Ana Viejo. I'm a GP. I'm currently working in Spain, northern Spain, in rural surgery. I also do some research in respiratory issues, mainly asthma and COPD. And I'm part of the International Primary Care Respiratory Group. Also, I would like to thank you, Integrity and IPCRG for counting with me for this presentation.
Thanks, Anna. So what we're going to talk about here today is talking about, based on with evidence-based information, to talk about how we can look for patients with early COPD. We're going to call that screening or case finding. We're going to talk about making a diagnosis and intervening early, because I think what I'd like to do is alter the course of this relentless condition if we possibly can. So the first is the why, and this is some work done in the Lancet from 2017 that looked at patients who had no COPD versus those people who are not undiagnosed yet, who either did not have symptoms or had symptoms. And what you can see here, and whether or not it's adjusted for age and sex or also for tobacco, which is the line on the right, that whether we look at exacerbations, respiratory mortality, or all-cause mortality, there's clearly an issue here in terms of patients who have not yet been diagnosed having a higher risk. And the more symptoms they had, the worse it was. Pneumonia, that signal is also there. So the message here is that patients who are undiagnosed still have significant morbidity and potentially mortality. So we have to find these people, because if we don't, we can't intervene and make a difference. Now, this is a lot of respiratory symptoms I showed you on this slide. But what I want to look at on this slide is the comorbidities. So COPD, as you all know, is much more than just a respiratory illness. There's systemic inflammation that causes, and related to many morbidities, be it, as you can see, hypertension, diabetes, myocardial ischemia, metabolic syndrome, and obesity, and many conditions here. We'll touch on those a little bit. But they're not all in patients with severe disease. And you can see here that they actually start fairly early on in the illness. So the mauve color at the end is gold 4, the red is gold 3, and the green is gold 2, and the blue is gold 1. These are all lung function measurements, and we'll talk about those in a moment. But what you can see here is these conditions all occur early on. So if we say we're going to wait till patients have severe COPD to start paying attention to them, we're going to not be able to optimize our management. So when we make a diagnosis of COPD earlier, we can also start intervening with conditions like treating blood pressures and lipids, and even bone health, to make sure that they don't progress down the road. But looking particularly at cardiovascular, if you look on the right side, these are patients, again, you see, first of all, blue is cardiac issues, and you can see that this happens in moderate disease. So in fact, patients with mild to moderate COPD are more likely to die of cardiovascular illness than they are of respiratory illness. And you can see then as well that we have respiratory illness on this more severe disease that's much more likely there. The red is looking at lung cancer. And one of my jobs, I'm actually a primary care cancer lead in my region. And we do lung cancer screening, which I know is not being done everywhere around the world. But patients, of course, who are smokers of a number of years at a certain age are at higher risk of lung cancer, and therefore we start doing lung cancer screening with low-dose CT scans. But the evidence has been quite clear that having COPD on top of that smoking is actually a higher risk of developing lung cancer as well, even more important for us to potentially be screening those people. On the left side of the screen is talking about overall the risk of concomitant comorbidities with the COPD, and you can see the increased risk of mortality with ischemic heart disease, atrial fibrillation, diabetes, and heart failure, significant numbers, especially that heart failure number is really scary with an increase of 90%, almost doubling the risk of mortality. So having COPD and comorbidities is a dual sword. And most importantly, it means we have to be aggressive about treating those conditions and hopefully even preventing them so we can have the best outcomes for COPD patients. So when we make a diagnosis of COPD early, it's also a matter of starting to treat their other conditions at the same time. Again, this is looking at mortality. In this trial, it was 1,200 patients in this trial looking at the risk of mortality. And you can, sorry. And you can see here, always happens, right? You get a phone call in the middle of a presentation. You can see here the mortality risk. It's my car's in the shop. That's why I got the call. Anyhow, you can see here that the risk is not insignificant across the various parameters just here as well. But again, it's not just gold 3 or 4. It's gold all the way down to gold 0. Gold 0 we don't talk about anymore. It's people so-called pre-COPD, and we're not calling that COPD anymore. Gold does no longer calls patients without symptoms COPD. But you get the idea here that these risks actually start very early in mild to moderate disease. What this means then, this is the Arctic observational cohort study that was also done in Sweden. And you can see here again, this is the probability of no exacerbations. So the higher the line, the better things are. And you can see people that make an early diagnosis have a higher likelihood of having less exacerbations and even potentially even a little bit better survival on the bottom right corner. So what this means is if you make an early diagnosis, you can actually start instituting therapy. Now, there is some controversy about how much effort we should put into making an early diagnosis. We'll talk about how to do that shortly, because all patients should be told to quit smoking anyhow. And that's been a controversy for many years. But I'm hoping that what I'm showing you here shows that there really is a benefit to doing that. And that's what the group really actually felt was the right thing to do. So making a late diagnosis means the patients are at higher risk of many things happening. So with this whole concept, most patients with COPD, by the time they're diagnosed, have already lost probably about half of their lung function, right? That's an MRC scale where you start getting a shorter breath as people around you, and I will show you that in a little bit. So that's when people usually notice the condition. So we want to find that a bit earlier. So therefore, we can hopefully decrease morbidity, decrease mortality, treat the comorbidities, and make sure people get vaccinated, prevent exacerbations, and institute therapy a bit earlier, improve quality of life. Now, while there's no medication therapy that can reverse this condition, there's a little bit of evidence from the SUMMIT trial, which is an older trial done a few years ago in patients who are high risk for cardiovascular disease, that actually we may be able to slow down lung function loss with some treatment. But that's not really what we're pushing here. We're not pushing that medication is going to affect the disease. What we're pushing here is making an early diagnosis so we can institute all those other therapies, exercise, vaccination, comorbidity management, and of course, treat the symptoms as we would otherwise. Now, with that said, of course, there are some real barriers to making an earlier diagnosis of COPD. We broke this down to the 4 different categories. So you can see here, we'll start with the patients. Patients with COPD, as you all know, tend to not recognize that they have a condition. They use all kinds of excuses. Well, I'm a smoker, so I expect to have a smoker's cough. I'm getting older. I'm a little less fit, therefore I'm a little more short of breath on exertion. And of course, they don't want to actually get into the fact, they don't completely complain to their doctors about shortness of breath because they know they're just going to get yelled at about their smoking. So with that underemphasis of symptoms and suffering in silence, they're actually not reporting to the doctors. And therefore, we as clinicians don't jump into, hey, wait a minute, you're short of breath, maybe you've got COPD. From our point of view as clinicians, we may not recognize some things are related. Having recurrent chest infections in a smoker, they're probably exacerbations of COPD in a significant number. We should look for them. Non-smokers are not even considered to have COPD. We know that 10% of COPD patients, if not a little bit more, will have COPD from other exposures, be it occupational exposures, or a very common one is biomass fuel exposure. Imagine growing up in a country, in a place where you live in a hut, and that hut is where the smoking is done and there's no ventilation. So these children are growing up and the women are living in an area of high exposure to irritants to their lungs that destroy their lungs just as readily as cigarettes will. So think about that when you have someone who's coming from a place or lives in a place where they've had significant exposure to biomass fuels. Oftentimes, only the heart's important. We don't worry about the lungs as much, so we pay attention to the cardiovascular risk instead of also thinking about COPD, but recognize that COPD itself is a very strong cardiovascular risk factor. There's a gender bias in diagnosing COPD. A friend of mine, Ken Chapman, did the study years ago where they gave a fictitious case to a bunch of doctors, exactly the same information. The only thing that changed was men or women. The men were diagnosed with COPD, the women were diagnosed with asthma, even though the patients were COPD patients. And of course, as I said, maybe we don't actually look for COPD because, again, smoking cessation is really the major thing we can do to affect the ongoing morbidity and mortality risk. So we're going to, of course, say about that anyhow. There's a real difficulty in getting spirometry in different places around the world. Can you get it in primary care? Can you get it in secondary care? Won't even get into COVID and the whole fact, of course, many lung function laboratories were closed down, may not be funding or availability for it. And of course, if you do get it outside the office in a clinic or in a hospital, how fast does it take to get the report to us in primary care? And then, of course, there's just some real logistic concerns. Listen, we're all busy people. None of you are sitting around having coffee and tea during the day. You're actually seeing patients with a lineup out the door, and how much are you going to go looking for trouble when you already have enough complaints that patients have coming to us? So with that and the epidemics, we have a lot of time constraints on us, and that's very real. That being said, this is some work that we did in the Lancet, first author Rupert Jones, that looked at the 10 and 20 years prior to a COPD diagnosis being made. We went back into the database to look and see what happened to these people and whether they had infections, antibiotic prescriptions, chest x-rays, or even prednisone prescriptions. You can see that wasn't enough of a note to the family physicians to say, wait a minute, something's going on. Now, I understand people get colds all the time, but if they have colds and they're short of breath, that's a problem. If they need prednisone, that's a big problem, right? So with all that, these are opportunities we've had to make the diagnosis earlier. And now, hopefully, with the education we're going to give you here today, we'll be able to do that. So I'd like to introduce Dr. Viejo to talk about how we can actually find COPD earlier. But Anna, from my point of view, I've talked about why. So what I'd like you to talk about now is how we can recognize these patients in our practice.
Thank you, Alan. Yeah, so now that we know that early COPD diagnosis is crucial, we have to think how we are going to identify those patients in primary care in our clinics. So the key point here, I think, is having a proper clinical history done. And the key point are obviously the symptoms, okay? So we know that the main symptoms, COPD symptoms, are the shortness of breath, chronic cough, and sputum. And probably that will help us to differentiate that disease from other respiratory disease as asthma. But as we are here because we want to identify early diagnose, probably most of these patients that are going to develop the COPD, at this point, they don't have even a symptom at all, okay? So the tool that we have to screen COPD earlier will be probably the symptom questionnaire or self-administrated questionnaires, okay? We are going to present you three. This probably is well known by Alan. This is the Canadian Lung Health Test. As you see, it's got 5 questions on it. If the patient asks yes to any of these questions, referral should be made for further assessment, including spirometry, of course. The CAT will be 40 smokers and ex-smokers around 40 years old or over. At the IPCRG, we do recommend 35 years old in Spain as well. So around 35, 40-year-old patients who are ex-smokers or smokers, we will recommend to go through these questionnaires. The second screening questionnaire is the COPD-PS, the population screener test. This one was developed by a group of Chinese researchers, and it was done over patients over 40 years old. Again, 5 questions. If the total score is 5 or more, that will mean that the breathing problems might be caused by chronic obstructive pulmonary disease, and therefore referral should be done for further studies. The third questionnaire that we wanted to talk about is the capture questionnaire. This one was published and validated at the end of last year. Again, we find 5 questions that should be asked yes or not. And the total score will be between 0 and 6. 0 and 1, there's a low likelihood of COPD, and therefore no further tests are needed. And if it's around 5 or 6, significant likelihood of COPD, and therefore we should refer the patient for further studies, including spirometry. So as you can see, I always say we should refer for further studies, and that's because the questionnaires themselves, they are not diagnostic, okay? The gold standard of diagnosis of COPD is spirometry, as you know, okay? And it's truth, and as Alan said before, it's not always available, mainly the couple of 2 years because of the pandemic. We haven't done much spirometry or none at all, depending on the countries. But you should know we have alternative tools like this one that I've got here. This is, I don't know if you're familiarized with it. This is the COPD-6 metallograph microspirometer. It's very easy to use. The technique is quite similar to the spirometry, but for the patient it's much easier. There's no need of preparation, okay? They have to blow through the mouthpiece for 6 seconds, okay? And this study, it will show us that this technique it's got a high sensitivity with an acceptable specificity, and therefore we can rule out COPD among patients with respiratory symptoms, which is very useful. So I think we all should have one of these in our clinics. But as I said, we need more spirometric measures. This is another one that has been published recently at the end of last year. It is a study on a new index that measures the low, because you know the COPD affects low airways. Right, so we are going to find out if this new index, FF3, FF6 ratio, that measures low affection on low airways, is going to be useful for early affection of the lung function. Okay, so this study was done over 800 patients. These patients, they were smokers and ex-smokers, and they did not have COPD. As you can see, the spirometry they did on them showed no obstruction, okay? So what they found out is that this new index, FF3, FF6 ratio, was associated with a reduction of this index was associated with low FEV1, high CAT score, which means high dyspnea, and high St. George questionnaire score, which means low or poor quality of life. Okay. Also, they found out that the patients who had a reduction of this index, because they followed them up for a year, they found out that they were developing more infection diseases, respiratory infection exacerbations. Okay, and those exacerbations were developed earlier than the other group. Okay, and therefore we can say that reduced FEV3, FEV6 ratio can identify those at risk for a future development of COPD and exacerbations. Therefore,
and if I can jump in here, one of the good things about this is a pre-bronchodilator. So one of the barriers to getting spirometry is being able to do a post-test with a beta agonist. But with this one, just a pre-bronchodilator test can give you a good indication of small airway disease.
Yeah, that's right. Yeah. So therefore, we've got another index that we can use in our clinics from now on. So just to summarize, we have this algorithm where we can see what we should do with our patients. As we said, smokers, ex-smokers, age over 35 years old, with a positive score on the COPD screening questionnaires, COPD-like symptoms, we should go for a standard spirometry. If the spirometry is not available, we'll go for the handheld device and find out whether they have obstruction or not, okay? If they do have obstruction, then we have to go for the diagnostic spirometry. If we don't have it available in our clinic, in Spain at least, we do referral to the pneumologist, okay? Also, just to let you know, if by any chance you have incidental emphysema finding on a chest X-ray or CT scan, we do recommend you do spirometry on those patients. If they are smokers, we should advise on smoking cessation and find out whether they have COPD or not. If they are not smokers, we should rule out alpha-1 antitrypsin deficiency. Okay, so now that we know how to identify COPD, the next step will be confirm the diagnosis. Okay. If so, how we can assess our patient's level of severity and future risk. Dr. Kaplan, please.
Thanks, Anna. So we're going to jump into that, how we make a diagnosis. Yep. And as per Anna's last slide there, where she talked about emphysema on x-rays, don't radiologists just love making a diagnosis of COPD, right? They'll suggest COPD, hyperinflation. They cannot make that diagnosis. So we have to make that diagnosis ourselves. And we do that based on spirometry, as Anna has said a number of times, which I'll reiterate because it's worth being said. Of course, people have symptoms and they have risk factors. Risk factors I've touched on already, being it occupational, biomass fuels, pollution, host factors like alpha-1 antitrypsin deficiency, which is a deficiency of an enzyme that breaks down the proteases that are released with inflammation in the lung. And if you can't break down the proteases, they chew up the lung in the presence of consistent inflammation and or smoking. So identifying that is important. It's a simple test to do it, at least in North America, and I'm sure most of Europe. It's a blood test for the alpha-1 antitrypsin level. I just don't do it during exacerbation because it's an acute phase reactant. At the end of the day, though, all those things lead you to point us to the need of spirometry. And we did talk about the barriers, and I know sometimes it's just hard for us to get. This comes from a desktop helper that we did 20 years ago, looking at the patterns in obstructive versus non-obstructive respiratory illness. And as I said, there's also a desktop helper being created on an early diagnosis of COPD that Miguel and I are updating this year. But this gives you a picture of that. So a normal one, you can see the shape of the curve. So we look at the volume time curve in the middle. Most of us look at the flow volume curve as the one that mostly gets reported, although the volume time curve is the one that tells you what's happening in real time a little bit better. But overall, if the ratio is low of how much you can blow out in the first second, there's obstruction. If the total FEV1 is low, then that means there's some kind of a restrictive pattern. So that's sort of what we're looking at. FEV1 can be low either because there's obstruction, or if the FVC is also correspondingly low, then it's just because of the restriction. So we really need all these different components. We need the shape of the curve. You can see the different shape of the curve, which is much more concave in the obstruction, more straight up and down in the restrictive. We want to see that, in order to be obstructive, the ratio has to be low and the FEV1 is low. To be restrictive, the ratio is usually normal because it's not an obstructive problem. It's just the entire lung function is down. Of course, the FEV1 is low. And of course, those are the easy ones. The harder ones, the ones with a bit of both, when there's both obstruction and restriction. And those take a little more work to tease out. But again, the principle is the same. The ratio is low, but the FEV1 may be low. Now, the most common reason for a low FEV1 in the context of a low FVC in the context of obstruction is hyperinflation, and often that can get reversed by bronchodilation. So the post-bronchodilator test is actually very important to make that decision, because improvement is consistent with asthma, and lack of improvement, of course, is consistent with COPD. So GOLD has given us these classifications for many, many years now. They've been fairly consistent. The only thing that's been removed is the GOLD 0 I mentioned earlier. So we talk about the lung function levels based on these strategies. So GOLD 1 is FEV1 above 80%. Again, all of them have a ratio less than 70%. It's a fixed ratio. You may hear things about less than the lower limit of normal. It's probably worth a mention. We actually have got a position paper on that in our IPCRG question and answer section that we started during COVID. Have a look at the IPCR website for that. But the issue here is that lower limit of normal is important for people who are older, because at that point they're less elastic overall, and people can have a bit of an obstructive looking ratio based on the fact that they're just not as elastic anymore. So it tends to overcall COPD, and the very young people tends to undercall it because, again, they're more elastic. But using the lower limit of ratio, the fixed ratio of 70%, which is easiest for most of us to use. If the FEV1 is more than 80, it's GOLD 1. If it's 50 to 80, it's considered GOLD 2. If it's less than 50, but more than 30, it's GOLD 3. And less than 30, we call it very severe or GOLD stage 4. Now, it's utilized in the GOLD algorithm, Global Obstructive Lung Disease, the international COPD recommendations. Again, we make a diagnosis spirometrically. Right? We have clinical suspicion, but then we make the diagnosis. We see how much airflow limitation is, and that's the GOLD stages I talked about. And then based on the quadrangle you see on the right, that's how we choose treatments. So we choose treatments here not based on the lung function, but based on things like the frequency of exacerbations, the amount of symptoms they're having. So a frequent exacerbator is considered more than 2 per year, or more than 1 hospitalization. But even frankly, one exacerbation gives you a little bit risk of future exacerbations. And certainly 1 hospitalization makes you high risk. Symptomatology, the CAT score above 10 is also considered that. We'll talk about that as well shortly. So we make our decision treatments based on the severity of the symptoms and the exacerbation risk after making a diagnosis with the lung function. And we'll touch back on treatment in a little bit. This is back to you. So Anna, with that, we've talked about how to do it. So how do we assess the severity of a patient? I've given us some hints on that, but I know there's some further things in the Spanish guidelines that you talk about.
Yeah, you're right. So the risk level must be evaluated. And the Spanish EPOC, the Spanish COPD guide, proposes a classification into 2 risk levels, low and high. The factors considered for risk assessment are the degree of obstruction measured by post-bronchodilator FE1, the grade of dyspnea measured by the MMRC scale, and the history of exacerbations during the previous year. As you see, these variables, they are quite easy to find out on our clinic with the patient. So that means that a patient with a higher risk will show at least one of these less than 50% one post-bronchodilator, grade of dyspnea between 2 and 4, and at least 2 exacerbations the previous year, or 1 admission. Okay. The higher the risk level, the greater the need for therapeutic intervention. We talked about MMRC and CAT questionnaires. I think you are very familiarized with them. You know, the cutoff for the MMRC questionnaire is the grade 2, and the cutoff point of the CAT questionnaire is 10/40. Okay. So both items, the MMRC2 grade and CAT-10, they are correlated. Also, there's a concept of COPD control with the Spanish guide. And this concept will be defined by the stability and impact that we'll find out with this questionnaire that you can see on the slide. Stability will be defined by the presence of lack of exacerbations in the previous 3 months. And impact will be defined by appearance, rescue medication use, physical activity level, and dyspnea grade measured by the MMRC scale. So that will be that a control patient will be the one with stability and a low impact, whether the uncontrolled patient will mean that it will be on a higher risk of reduced quality of life and a higher risk of exacerbation, and therefore intensity of treatment may be required. They propose us this COPD control to adjust treatment. I don't know, Dr. Kaplan, how often do you think we should adjust treatment on these patients?
Well, it's going to depend, as you say, Anna, based on this, on the severity of the situation and the expectation of further exacerbation. So if patients are non-exacerbators, then we aim our therapy based at symptoms and we bronchodilate until we reach an effective amount of symptom relief. If they're exacerbators, that's a little different. We're still bronchodilating, of course, because that's how we treat the problem, but we have to start using, based on phenotypes, medications to try to prevent exacerbations, because each exacerbation is obviously causing further damage to the lung. So exactly how you've laid this out, I mean, Dr. Miravetlis's COPD control idea is a newer one, and we were talking about how we can actually make differences based on that. But whether you follow this or whether you follow the gold algorithm, either way, we're stepping up therapy accordingly. This overall, we're talking about early diagnosis rather than treatment, but you're all familiar with short-acting bronchodilators, long-acting bronchodilators, dual long-acting bronchodilators, even moving to the fourth of triple, where you have ICS as well as a dual bronchodilator, and other medications such as roflumilast and even azithromycin to decrease exacerbation. So I don't think we have time to go into all of that because of that, but that just gives you a touch on that. And of course, don't hesitate to reach out if you have any questions.
Yeah, thank you. Just to finish, I would like to go through the key points. We're running out of time, so just remember that early COPD diagnosis is crucial for implementing early interventions that can prevent, exacerbations, preserve lung function, improve quality of life for our patients, and decrease morbidity and mortality. We should apply a case-finding approach for individuals with exposure risk and symptoms of COPD. Remember the questionnaires we've been talking about. You should consider case-finding with hand-handled devices if you don't have the spirometry available. And finally, we should identify and address any barriers that Dr. Kaplan talked about on diagnosis and may stem from healthcare professionals or patients or spirometry itself. Thank you very much. I don't know if we have time for questions.
I'm just looking into the chat. We don't really have much in the chat currently. In terms of some common questions that come up here, it's really about how do we do this in practice, and do we screen all our smokers, or do we just look for, as you described, case finding? And just to separate out that wording a little bit, screening means you take a population at risk and you do tests on that population to see if they have the condition. And neither Anna or I are recommending that you screen all your people at risk with spirometry if they don't have symptoms. But if they have symptoms, we should. So we call screening us for symptoms, not spirometry. It's actually been shown that's not terribly effective. It doesn't change patients' behavior. But that being said, we do screen for symptoms. So asking the questions, any of the different questionnaires that's talked about, we can certainly use. But once we find symptoms and people who are at risk for those reasons, then we should go on to spirometry. So you said there's
a question here. How do you deal with a patient who has no desire to quit smoking? We do have, at least in Spain, we have a smoking cessation clinic. Do you have that? Alan?
Well, smoking cessation is many of us the boon of our existence, bane of our existence. It's there. The simple answer, of course, is the 6 A's. You must ask everybody. You must look for all the different reasons of why they're smoking, whether they're going to quit, assess their readiness to change, to get an idea of whether or not it's worth having a long conversation today or a short conversation. And then moving on to try to assist them with pharmacotherapy and advice to that. And from there, also remember to go back if they have quit and maintenance therapy. Make sure that you go back and talk about the smoking, because unfortunately, the common thing is for people to relapse, which is difficult for us all.
Yeah, right. There's another question. I think that would be for you. Is it more common for CV disease or COPD to develop earlier?
I think that probably depends on the etiology, whether it's smoking or not. But the answer is that many people, the point I was trying to make is that many people don't start thinking about cardiovascular illness until it hits them in the face and it's obvious. But what Anne and I've showed you today is that actually shows up earlier on the condition of COPD. So if you go way back to Framingham data, and we're all familiar with that, the risk of cardiovascular disease, smoking, diabetes, hypertension, family history, and so on. If you go back to that data and you look at the data, the patients that had COPD had far and away the highest cardiovascular risk. So what I'd like you to consider here is that the diagnosis of COPD is a cardiovascular risk factor. And it's been shown that if you start treating with ACEs and aspirin and ARBs and statins, it actually improves the outcome and decreases mortality. So COPD is a cardiovascular illness. We don't think of it that way, but it starts off early in the COPD diagnosis. You shouldn't be waiting until they're very sick with their COPD.
Thank you. There are no more questions.
Okay, so I think that's about time. Thank you for everyone being patient. I know we're a couple of minutes over time. Again, I want to thank my co-presenter, Dr. Viejo, and all the team behind this that made this work. It was a short time, but a good time. And hopefully you're going to find the same thing happen on May 3rd, if you want to join Dr. Sally Singh and Claire Cook talking about non-pharmacologic management of COPD. And I'm sure we'll have other conversations about pharmacologic down the road. So make an early diagnosis, start those non-pharmacologic treatments, and then we can hopefully improve the outcomes for our patient. So that's next Tuesday, same time as this.